Welcome back to VME Vaginismus. Let's name it, not shame it. I am Audrey Cairo, and yes, we're back for a new episode in 2026. I know, I keep you waiting. I am very much aware of it. But please know that I'm so happy to be back because I do miss being in your ear to support you wherever I can. A long while ago, I asked on my socials what you might want to hear more about. And even if I'm not on socials a lot, one of you did come back and asked if I could share more about Vulvodynia. Some of you might know what it is, some of you might never have heard about it, and maybe that's the reason why it's so important to bring this topic to the podcast. While it has taken me a while to fulfill this promise, I am now so extremely pleased to share my conversation with Dr. Caroline Pukall. Caroline is one of the world's leading experts of genital pelvic pain, or vulvodynia, and sexual well-being, and she is the co-author of the book Why Sex Hurts. It was simply a joy to speak to Caroline, and while I was planning to ask all kinds of questions about the book, we kind of just simply spoke about vulvodynia, and I feel we kind of scratched the tip of the iceberg when tapping into her knowledge about both vulvodynia and vaginismus. I literally walked away with a lot of learning, and I hope you will too. Caroline and I discuss what vulvodynia is, what different types are there, potential risk factors that could play a role in developing vulvodynia in certain people, treatment, and also what the relationship is between vulvodynia and vaginismus. If you're experiencing pain, I do hope that you will listen to the podcast because it might give you some insight. As I always say, knowledge is power, so don't forget to stay curious along the way and don't hesitate to let me know what you think. And a good afternoon, I will say, to you, Caroline. I'm instantly laughing because we were just talking about all the time zones we're maneuvering, but lovely to have you.
Thank you so much for having me.
Yes, like I cannot believe it. I actually realized I think this is the first conversation I'm having, or not in general, but on the podcast with someone based in Canada. I
I'm
think
I'm
I think
honored.
so. I think so. I might have to go back. Maybe someone's going to come and tell me like Audrey, I was based in or in Canada. But I'm so happy that you made it here and that we finally are having our conversation.
I'm very excited. I've been listening to your podcast for for almost a year now, and I'm almost caught up, and I am
Yeah.
intrigued and so thankful that you're covering this really important topic. So
Oh,
I'm
thank you.
absolutely honored to be here today.
Oh no, I am excited now. Like you've been listening for a year. You are that extra percentage of people who are listening because I don't know. I'm making these podcasts not knowing that of course I do have some numbers, but I never know. And I do see that it's spread over the world, right? And
Yes.
this is the first podcast this year that I'm recording. And likely I
Oh
done
my
one
gosh, that's
last
amazing. Well,
year.
I have recommended your podcast to a lot of people as well.
Oh,
So
thank you. Thank you. Okay, it's not about me, Audrey. It's not about you. Like just grind it back because I'm like, oh, that's so good. I'm so happy to hear that.
it it is about
Yeah.
you.
Yeah, like I'm just happy that it reaches people who need to hear or who might not speak to you or that you are able to recommend if people are not ready. But while I was doing my little research, and I have to say, I could have done much more because at one point I put something in and I was like, what? I did not know that she just published another book. Um, and I'm like, I could have had all kinds of conversations about that. I could have read that one before we met. But I'm just so happy that you're here. Can I call you Caroline or should I say is it doctor?
No, please call me Caroline. Yes.
Okay, okay, okay. Because I felt it's either doctor or professor, or because there's so much that you have to your name. And mostly like thinking about when I was doing my studies and when I was doing just a little bit of research, like a tiny, tiny, that I still have to publish. Sorry, people. But like all the pub or all the research that you've done in the field, and so your name and also your peers and other type of names that you have collaborated with. That I just like, oh my god, it would be so good to speak to her. And I will tell a bit more about how we got in here first, but I would wish for people to know a little bit more about you first. So, from
Yeah.
all the titles that you might have, and all the research and the books, and being a professor, like, how would you describe yourself to start with, if you would do an introduction?
Absolutely. So, I mean, yes, I have lots of titles, but really I see myself as a professor of psychology at Queen's University. It's in Kingston, Ontario, Canada. And within that role, I run a lab we call it Sex Lab, which is short for the Sexual Health Research Lab. So you could find us at sexlab.ca. So I do a bunch of research in multiple streams, in the area of sexual science, and in particular in women and gender diverse individuals' health, and particularly in conditions that are very puzzling to the medical community. And that lead to a lot of fallout and consequences for people who are suffering from them,
Mm.
simply because they're not well understood, or because they exist in intersections of, sexism and discomfort, and bias within the healthcare system.
Yeah.
And a lot of these do involve the genitopelvic area. So, and so I exist in this space for much of my research. I certainly do have other research streams, but this is my real passion and the work that I've been carrying through over the past 20 plus years. Within my role, I also teach. I certainly am in touch with people who get the word out, like yourself, Audrey. So, I certainly do lots of interviews for print and other kinds of media. I'm also a practicing psychologist, and so I run the sex and relationship therapy service through the Queen's Psychology Clinic at the university, where I train student therapists in sex and relationship therapy. And a large part of that work also goes to people who have genitopelvic pain and who are struggling with the fallout of that.
Yeah.
And I publish books as well for healthcare providers, and as well as for people who live with genitopelvic pain, or vulvodynia more specifically.
Yes, yes, yes. Like, I'm like, yes, and that's what I came across, that I was like,
Yes.
and how will I sum it up? You summed it up much more perfectly than I did, of course, but it's so much, and I think it's so great to have you, as you said, because it will be, again, a whole different perspective and a different conversation that we might have than I have had before. One of the reasons why I also reached out to you is that I think it's over a year ago, over maybe a year and a half ago. Okay, my concept of time is nothing anymore. But I had read the book When Sex Hurts, and I put it aside. But then I also, with the podcast, I was like, what to do? Where am I going next? And this is an ongoing question. But I had put a question out there for people on Instagram. And my Instagram is little, like I don't care about it. But I just thought, who is there I do value? And I said, what is it that you wished that I might cover still in the podcast? And someone came back, could you cover vulvodynia? And the reason why I think it's important, especially in combination with vaginismus, is that sometimes we just simply don't know what's happening, and there might be certain pains, as you mentioned. There might be a lot of shame, a lot of judgment, a lot of misdiagnosis. And after reading the book that you co-authored, I was like, oh wow, there is so much that I can't sum it up in any way, because there's so many different conditions or challenges or that we might not even know about unless you're researching it. So I'm so happy to have you here, where I will come back to the book, and I will also come back to the book that you've written. But what I would love to of course, speak and hear about is, yeah, I just want to pick your brain. That's the thing. I was just said it would be lovely just to get the knowledge you hold, and you might just say, like, hold on, Audrey, let me just get this part of who
Yeah.
knows, but it's just so much. There's so much, and Vulvodynia was one of the questions. And I know that there are amazing podcasts out there and information about it, but I think sometimes when we're looking in one direction, we might not know. And I've had people who I've coached with who later on found out that they have a different type of condition, that they might not have vaginismus, or vaginismus was on top of it
Yeah.
as a result of it. But they did not know that from the start.
Yeah.
But before I dive in and ask what vulvodynia is and all the things, I'm curious, how did you get to, how did this become your interest? Because I always feel everyone who I interview, they have a way in
Yeah.
somewhere. And so I'm curious about yours too.
Yeah, and I've been reflecting on this a lot, and trying to really sort of find out where it started. And I have to say that I have to thank one of the nurses at my grade school, for stimulating sort of this interest in sort of sexual health generally. So I grew up in Montreal, Quebec, and we had, unlike other places in Canada, at the time, my particular school had excellent sexual health education. I don't know how this happened because I'm also a Gen Xer, and so this is very unique in terms of most people's experiences of my generation and in younger generations. Typically, sexual health ed is, not very truthful, not very expansive, not very inclusive, and not very helpful. It's more sort of, scary, and sort of riddled with problems and misinformation. But for some reason, I just had a really great experience with my sexual health education. And of course, it was always very age appropriate. Like throughout my grade school and my high school, it was age appropriate. And the sexual health education was actually rolled in as like part of our science course. And it wasn't taught by the bio teacher, it was taught by our school nurse. Her name was Jackie, and she would, take care of any scrapes and boo-boos that would happen on the playground. And she would come in and talk to us very factually, yet very friendly and professional, to a group of very awkward, children who were fascinated, but also in disbelief and giggling and, just being completely dysregulated in class. And she handled the topic and she handled all of our questions just amazingly. And I think she was the original inspiration where, I really felt like a special person needs to handle this very complicated, almost taboo, uncomfortable sort of conversation or topic of sexuality, if I want to be really broad.
Yeah.
And, throughout the year, she always had a little box outside of the nurse's office. If you had any questions at all, you could write it down and pop it in a box. And from time to time, she would come to the class or during an assembly, would read the questions out loud and answer them
Wow.
because, of course, they were anonymous. And she never like laughed at a question. She just did it with such professionalism and care and provided us with the best sort of information possible. And I thought to myself, I sort of want to do something like that later. And so it really opened up my curiosity about being in a helping profession. And so I decided I went to this 2-year college sort of transition after high school before university. And I just threw myself into biology, psychology, and there were some sexuality courses.
Yeah.
So I took, sort of the entry psychology courses. Then I took the human sexuality course. And I thought, oh my gosh, this textbook is full of research. Not only do I want to help people like through talking to them, but I also feel like I could do research that can help people if they
Mm.
are struggling with, sort of their own, well, with any aspect of sexuality, right?
Yeah.
And so then I entered eventually into an undergrad psych at McGill, and then eventually entered into the clinical psychology. I did a bunch of experiences, like lab-based, hospital-based,
Yeah.
and just sort of just narrowed my interest a little bit more and got more and more experience as I sort of went through, and then wound up in a lab in grad school
Yeah.
where I could do research, and my supervisor was not only a researcher, but also a clinician and ran the sex and
Mhm.
couple therapy service through one of the hospitals affiliated with McGill. And I really felt like this was my space. I also have a feminist streak.
Yes.
And so when it became clear to me that this topic of sexual pain or dyspareunia existed as an area of research, I was quite compelled to help, women and underrepresented populations who were experiencing this because the message I heard when I interacted with participants, I was helping Sophie Bergeron, who did the first randomized trial in Vulvodynia treatment that was published in 2001. We're going back a long time ago.
Yeah. Yeah.
I was working with her and working with the participants in the study. And the most common thread I heard was, oh, people told me this wasn't real. People told me to drink alcohol. People told me it was due to abuse that I've never had. I
Mm.
felt gaslit. I felt dismissed. I was invalidated. And here is this lab doing this work. And we feel heard and we feel like this is really important.
Yeah.
And I would help with I would help explain the study. I would attend the gynecological examination with the gynecologist. I would take down the pain ratings.
Hmm.
And it was so clear that these were healthy looking individuals with healthy vulvas, but who had absolutely excruciating pain.
Yeah. Yeah. Yeah.
And I said to myself, I want to help people with this condition. It is so clearly there. And I think we need to adopt another
Mm.
lens to look at it that is apart from medicine, but that can inform medicine.
Yeah. Yeah.
And
Yeah.
so a lot of my early work was just working in the space of measuring thresholds, looking at sensitivity, listening to people's stories, and breaking sort of into sort of the clinical spaces, the more medical spaces, with information that this is a pain like other pain conditions.
Yeah.
Just because it affects the vulva doesn't mean it's not real, doesn't mean it doesn't exist,
Mm.
doesn't mean it should be, put away. Yes, it's inconvenient,
Yeah.
but, for multiple reasons, and it puts a lot of discomfort in that clinical interaction, but it needs to be taken as seriously as other pain conditions are
Yeah.
taken.
Yeah, certainly. And it's just interesting as well when you say, when you go back, like I think any research or if women's health or anything like has it's just slow, but
Yeah,
it's so interesting of knowing that the research is there and knowing
yeah,
that people are spending time researching this, but that it seems to
absolutely.
not necessarily come to the main street to of understanding it. You know, when I hear you say, "Oh, 2001, this is what that was happening there," and of course, I'm sure that there's many, many years before that that people were researching. Even for myself, when I think like, okay, so I found out about vaginismus in 2004, and this was again in another area of the world, and it's like, but now we're still having these same conversations.
Yes,
And one of the books that I saw that you published was or co-edited was a medical textbook I saw.
yes,
Yeah, and there was like
yes,
female sexual pain, but
yes,
like and because earlier you mentioned as well dyspareunia, and
yes.
and that's the medical term, right, for genital pain, right?
Yeah, so specifically pain during sexual activity that involves penetration. So,
Yes, yes. Because what I have found so interesting when one was reading one of the books you co-authored, but in general was that there's so many terms.
yeah.
And it's
Yes, yes.
so confusing. And it's so many terms,
Very
also
confusing.
different terms in different medical books.
Yeah,
But one that what I said that I hope to get a little bit more light on from your perspective is vulvodynia. And
yes.
let's pretend that I don't even know what it is, right? How would you describe to someone who doesn't know what
Yeah,
what it is like? Because yeah, that's just the question. What would you say that it is?
yeah. So vulvodynia is chronic vulvar pain that exists without a clear explanation. So like the vulva is part of the genitals. It's the most superficial sort of level. It's the part of the genitals you see when you look at the outside of your genitals. It involves like the outward sort of vulva, as well as sort of areas sort of a little bit inside, like the labia, the inner labia, as well as the vestibule, which is the vaginal entrance. So vulvodynia is specifically pain in the vulva, and there are multiple different kinds of vulvodynia. So there's generalized vulvodynia, where the pain is generalized to the entire vulva. So all of those areas are affected by pain. There's localized vulvodynia, which is where there's pain on the vulva that is specific to a particular area. So it could be the vaginal entrance, which is called the vestibule. So one of the most common causes, like one of the most common types of vulvodynia is called provoked vestibulodynia. I know these words are not easy to sort of come out. They're very technical. But when you really look at them, they're very descriptive.
Okay.
So provoked means the pain happens in response to contact or pressure to the area. Then vestibulodynia refers to the area, the vestibule. There's also clitoridynia, which is pain restricted to the clitoris, unfortunately. Okay. Yeah, we have a few studies that are ongoing on clitoral pain right now in the lab. And so you could have the generalized, where the pain is kind of everywhere. You can have the localized, where it's a specific area of the vulva. And then I had mentioned provoked pain. So provoked where, if there's nothing really touching the area, the pain isn't present, but the minute contact or pressure is made to the area, the pain occurs. And there's also something called spontaneous pain, which is where the pain is constantly present, or almost always constantly present, even if there is nothing obvious, sort of like a touching or putting pressure on the area. Okay. And so you could put those two things, like those sort of like the pain presentation and sort of the regions sort of together. And there's multiple different kinds of vulvodynia that you can have. But simply, it is chronic, unexplained vulvar pain, which can have as a symptom something called dyspareunia, which is sexual pain. Exactly. And if we take a bigger look at sort of like an umbrella, vulvodynia can exist in this really big sort of genito-pelvic pain sort of category, where it's then a bit more specific to the vulva, because we could, of course, have chronic, like more deeper pain with endometriosis, for example. Yeah. But so it's like genito-pelvic pain, so pain affecting the genitals and or pelvic regions. Vulvodynia is one kind of that, and then there's multiple kinds of vulvodynia in there with different symptoms that can occur.
So because of the pain, and because of the different types of pain, and because of I don't know how to say this, like how to be subtle about certain things, but what we said earlier about the misdiagnosis and etc. What could be a relationship with vaginismus? So because I hear sometimes when I hear people talking about vaginismus and they are describing a certain pain, and I'm like, interesting, because I have kind of in my time thinking, I made it very practical. Right? I've been like saying, okay, it's a spasm of the muscle. That is it for me. This is how I have experienced it when I had it. I didn't have any pain. It was simply the doors were shut. Then, of course, over the years of like speaking to people, you hear pain here, there, but also where it's become tricky to say, but is that then vaginismus or not? Yeah. Or have some clinicians or GPs said, oh, I think you got vaginismus, where actually they're not maybe aware of all of it. So what is the relationship between the two?
Yeah, absolutely. That is such a good question. And you're right. It's not very simple, and everybody experiences sort of vaginismus in a different way. There's a huge continuum, and different healthcare providers may be using the term in very different ways as well. So what we typically will find is that in people who have vulvodynia, there is typically a very common reaction to pain that is happening in the body, particularly the pelvic and genital region, where there is increased muscle tension. That is the body's typical response to protecting itself against pain. And this is not something that people are usually in complete conscious control over. People can have, like people who are stressed out, may have just heightened tension in their neck and their shoulders, right? And may not even be aware of it until they go to a physiotherapist, until they go to a massage therapist. And it's very difficult to sort of like relax those muscles just kind of on your own. You need some help. So when you have, in response to stress, in response to pain, if you have pain or you're thinking or you're particularly stressed or you're anticipating pain or you're anticipating a kind of a negative outcome of something, your body will naturally tense up to protect itself. And that is supposed to be very, useful. Just like acute pain is very useful. It signals you need to slow down, you need to take care, right?
Yeah.
But when we talk about more chronic tension or we talk about more chronic pain, the usefulness of that signal is a little bit, it's a bit lower. It's not as useful because your body is just holding that and the initial threat has gone away. So many people, and it's been demonstrated in my studies and in studies of other excellent research groups out there, show that individuals who have vulvodynia, on average, will have heightened muscle tension in their pelvic floor. And this makes sense because they have pain.
Yeah.
They insert a tampon, they engage in penetrative activity. The pain is there, the body is going to just, tense up to protect it. Now, the tensing is not necessarily helpful. It doesn't necessarily protect the area. It can sometimes increase the experience of that pain. Now, so they have more pain than, let's say, a control sort of group who doesn't have any of the pain. But that vulvodynia group will have less pain than people who are identified as have less pain and tension. They'll have less tension, than a group that will have what is being called kind of more classic vaginismus. Mm. And it makes sense, right? It makes sense that you have pain, you have this increased tension, and then you have sort of this other sort of part of that continuum, which is where sometimes the pain is so severe that the vaginal opening is closed for business, as you say, because the body is rejecting any kind of contact that will lead to that pain because it is extremely severe. Yeah. So certainly people with vulvodynia may also have a comorbid or, as we say, like they may have a second diagnosis of vaginismus because the pain is present, but there's also severe tension that prevents penetrative activities, whether they're sexual or non-sexual. There is also people with vaginismus who have zero experience of pain, right? But who still have that kind of lockdown in terms of their pelvic area and vaginal opening. And sometimes when you dig a little, there might be a really strong fear of pain. There may be just sort of almost like an automatic response to not let anything in. And it may not have anything to do with pain. It may have to do with fear of the unknown or fear of being injured. Or it can be something that is just very, very difficult to describe and articulate why your body is kind of acting that way and reacting to certain things in that way. And so there is a variety of sort of these intersections between pain, muscle tension that don't necessarily always involve pain for people with specific vaginismus. Yeah. What we see in people with vaginismus typically, not every single person, but on average, is sometimes a fear of pain or a fear of something going awry with penetration. And sometimes we just see a lot of just sort of avoidance of, penetrative activities because there is just sort of fear of the unknown of what if something comes inside.
Yeah.
Right.
Yeah. And we don't sometimes even know what the body registers, of course,
exactly.
It might have been a pinch, it might have been a this, it might have been a that, or it might have been as big as thinking about vulvodynia and actual pain that is reoccurring.
Yes, and some people I talk with, and we're doing a study right now on people with vaginismus, just like what sort of messages did you hear about sex growing up, right? And we're starting to actually see a lot of people saying, we heard that pain, like that first sex was very
Yeah,
painful, that people may bleed, that it was something that was a shameful, dirty thing to do, and you should not do this, before marriage.
yeah,
And so our body holds on to that information in very interesting ways,
yeah,
right?
yeah.
So if your sexuality has been locked down because of messages that you've been receiving growing up in a particular family, in a particular culture, in a particular societal structure, and you associate anything in that area with being bad or dirty or shameful or wrong, that can actually have implications for
Yeah.
sort of your ability to engage, in sexual activity later in life. And unfortunately, just getting married does not undo those many years of internalizing those
Mhm.
societal messages, right?
Yeah.
And so extra help is needed.
Yeah, like I think or we sometimes forget of how powerful like our or actually how it's one big system and our mind and what it is we hear and all the messages that it doesn't just is not a separate thing from our body either. But
Yes.
thinking
Everything is,
about
yeah.
yeah, but
Everything's interconnected. Yes,
exactly,
absolutely. Yeah.
exactly. And then thinking about vulvodynia, it makes a lot of sense that if it is an extra layer on top, if vaginismus could be an extra layer on top, because yeah, if you are having one of anywhere pain around the vulva, that your body wants to try to protect you.
Absolutely.
So because of it's not something that one can always see, and this is where
Exactly.
it becomes tricky.
Yeah.
I have like I think three questions at the same time in my mind that I want to ask you. So I'm just gonna pause for my or not pause. I'm not gonna pause the recording or anything, but just for myself to be like, what is it? Which question is important? I feel they're all important, but
Yeah.
but do you have an idea about what can cause the pains? Because
Yeah.
it's a pain. Some would
Yeah.
say, okay, something might have happened. For some, it
Yeah.
might just be that way.
Yeah.
Also, I'm reading the book of When Sex Hurts. There were so many different things that I wouldn't even think about nerve endings and belly buttons and
Yeah.
all these things. Then I'm like, whoa. But what has stood out for you? What were your findings so far?
Yeah, and so we don't have like one definitive cause of vulvodynia, one definitive cause of vaginismus. We all agree in the field that these are conditions that are multifactorial. That means that there are different sort of causal factors that play a role in these conditions, and very likely in they are different from sort of person to person. So, the best we could really talk about in terms of what causes these conditions, and in particular vulvodynia, we don't have a ton of information with respect to vaginismus as a separate condition at this point. But for vulvodynia, we do know that certain things play a role. Now, what I'm going to say may not play a role in each person's trajectory. There seems to be sort of this sort of individual vulnerability factors to developing sort of vulvar pain conditions that are then, sort of there are a series of what I call unfortunate events that sort of lay on top of this individual vulnerability that then have to pass a certain threshold to get that condition.
Yeah.
And these thresholds and the factors differ from person to person, such that different people may come to develop this condition from sometimes very separate, sort of pathways. Um, and so, what we find in the literature are sort of these factors that we call risk factors. So, certain things in people's histories that seem to be more common in people with vulvodynia than in people without. But again, these factors are not necessary and sufficient. They're not going to play a role for each person with vulvodynia, right?
Okay.
And that just it makes it complicated, right? Simply because people are like, oh, but I heard X was part of the cause and I don't have it. So why do I have this? So I think it's important to know that it really is sort of an individualized pathway to get to vulvodynia. But the good news is that no matter your pathway, there are effective treatments out there. But
Okay.
let's talk about some of the very common sort of like risk factors that are out there.
Yes.
And so one of them is sort of a history of repeated yeast infections. And so many people who go on to develop vulvodynia have been shown in research to struggle with repeated yeast infections. Again, there are tons of people with vulvodynia who've never had a yeast infection in their life.
Yes.
Okay. So we know that there is something about a vulnerability in the vaginal sort of environment that could play a role. We're not entirely sure if it's something having to do with the yeast imbalance itself or something with the treatments of the yeast infections,
Okay.
right? So
Okay.
we are not entirely sure, like, or if it's a combination of the two, we are not entirely sure, but we always recommend if you think you have a yeast infection, do your best to get an actual diagnosis. And if you feel that, you're sort of on a track to develop vulvar pain, if things are already sensitive in that area, if you are someone who is very predisposed to getting yeast infections, we usually will recommend that people use an oral medication to treat the yeast infection instead of something local that you can get over the counter, simply because it might be some like mysterious mix of the chemicals that are being applied vaginally to treat that yeast infection. But also, you may think you have a yeast infection that you are treating, but you in fact may not have a yeast infection. It may be something else. So it's always
Okay.
good just to get just get a swab done to confirm that it is what it is and have that conversation with your healthcare provider about an oral medication to help.
Okay.
So that's one thing. So this history of repeated yeast infections, and that I guess that sounds kind of abstract. That is sort of defined by many people in the literature and in sort of the clinical spaces as around 3 or more per year.
Okay. Okay.
Okay.
Okay. Yeah. Yeah.
Another thing that emerges from the research is the early use of hormonal contraception. And so certain research has found that people who start on hormonal contraceptives at an early age, and in different studies, this is either between like before the age of 14 or before the age of 16, they tend to have an increased risk of vulvodynia later in life. And it's not clear if there's something just with a hormonal shift that renders that part of the vestibule or the vulva to be more sensitive or to sort of just be more sensitive to stimulation.
Yeah. Like,
Another,
can I just say that my
yes.
mind just blew there for a second
Oh,
because I was
okay.
like, because
Tell
I'm,
me more.
no, just because I'm like, oh, yes, like that is so, we don't speak about the effects of hormones or
No.
actually birth control or anything. Like, from a young age, we might start it without knowing what the effects are on our bodies.
Exactly.
And I can only imagine that, I want to say like as the different hormones develop over time, that as you said, if it comes later on, it might be not the right time to be taking something or
Yes,
whatever, who knows, right? But as you said,
exactly.
it might clash with what your body naturally is trying to do and what it is you're taking. So I just went with
Exactly.
like
Yes.
my mind just
Yes.
blew like thinking, oh
Yes.
wow, that is so interesting, a very interesting topic, especially thinking as well of women perimenopausal or menopausal and like I'm in a perimenopausal phase, so that's another interesting topic for me.
Oh, I
I'm
am
sorry.
too. We
So,
should have a separate podcast on that.
exactly. But it's that thought of like, oh, all the changes, what might happen, vaginal dryness, la li da, all the things. But as when you said, contraception, like I remember I quit over now 18, 19 years ago because I had like, I had migraines and like my body was really trying to say, don't do it now.
Yeah.
And it's interesting because, sometimes you just persevere and you go through it, but you won't know sometimes if something can harm you, but it's something to think about. So if it would be not, as you said, it might not be everyone. That's what
No,
everything that you just said,
and it isn't. Yeah.
but
Tons
it
of
could,
people who don't have vulvodynia are on hormonal contraceptives like since the age of 12,
yeah,
right?
yeah,
So,
yeah.
yeah.
But
Yeah.
it's, if that would be the case, and if someone is like, oh, okay, that's interesting because that might be the case, is then it just a case of seeing what happens to your body when you stop taking it? or
Well, that's
or
a
where you
that,
speak to your GP or like see to
yeah.
roll medication back in that sense.
Yeah, absolutely. So, you have to sort of offset, sort of like, so if you feel, so especially, so you want to look back and sort of think to yourself, when did my symptoms start? Right. And then if they started at around the time you started a new medication, such as a hormonal medication, you may want to trial just getting off that medication, seeing what happens. So it is not as simple as that all the time, but I certainly, in my very long career, chatting with thousands and thousands, tens of thousands of people with vulvodynia. Certainly, some of them said, actually, like stopping the birth control pill, was my solution. There was something in that just tipped me over into like a hypersensitive sort of, vulva. And for me, the answer really was simple. And I got off those medications. I use an alternative form of birth control, and it works wonderfully.
Yeah.
And so this is something that you should always just be careful about because obviously you need a backup protection.
Yeah.
Having an unwanted pregnancy,
Mm.
at a bad time in your world, can be quite devastating for a lot of people, and maybe worse than the pain, right?
Yeah,
So
yeah.
just make sure that if this is something that you're going to try, then you are protecting yourself in an alternative way, for that time, and not just against pregnancy, against STIs and things like that, right? So,
Exactly. And like I think with any type of medication, as you said, like to do it in an environment that is observed by, if it's your doctor or someone that who has the, like, not just because we just said like rail it back. No, that's not it. But it's more about, it's something to be thinking about, like what else is happening and what is that I'm taking that
yeah.
might contribute to that. But okay, I know I interrupted you, and you were
Oh no,
you I
it's
interrupt
all good.
I interrupted you because you were not there yet with what also could be a potential risk factor, or risk, was it a risk factor, did you
Yeah,
say?
a risk
Yep.
factor. So
Yes.
hormonal birth control or hormonal contraception can be a risk factor for vulvodynia.
Yes.
Also, so I mean, there are quite a number. I'll go over sort of the main ones just so that we could, and then of course, if any listeners have more specific questions, they can reach out to me or reach out to you. Another thing is something that we don't have a lot of control over. So there seems to be sort of this whole area, and I won't get too technical about it, but sort of this whole area of like our genetics as they relate to how our body responds to it, like, sort of a threat in terms of inflammation. So, you have an injury, right? There's like, a response that kind of happens. Part of that is an inflammatory response. What we see and what the research has shown, and I don't work in this space myself technically, is that people who have vulvodynia tend to have genetics that favor an inflammatory response, where that inflammatory response turns on very easily and is difficult to shut down.
Mm.
And this can sometimes and inflammation can lead to pain, and it can lead to sort of like a higher proportion of pain fibers in an area. And so, and we don't have control over this. These are genetic and epigenetic factors that we are simply born with and that are sort of modified over time within our environment. And so there is something about like some kind of inflammatory vulnerability,
Yeah.
in many people, but not all people with vulvodynia, again,
Yeah.
right?
Yeah. Yeah. Yeah.
Certainly more common, but not, sort of the only answer. And certainly, research has found that people who have experienced trauma in the past, whether it is like physical or sexual, as well as mental health diagnoses, such as depression and anxiety, are also at higher risk for developing vulvodynia. Now, I don't want to say that this is the only sort of like pain condition that is associated with these factors. Many pain conditions and many health conditions are associated with trauma. There is something about in like experiencing trauma or experiencing severe psychological distress that somehow may tip the balance of a variety of health conditions, including pain conditions, including vulvodynia, because of the effects that these have on our bodies in terms of our stress, in terms of our immune response, in terms of our epigenetic factors. So these are factors that open and close a particular area on a gene to make us more or less vulnerable to certain things. And so certainly, there are not only sort of these more physical factors, but also these psychological factors that can play a role in sort of like our propensity or our sort of like threshold of developing vulvodynia.
Yeah, yeah, yeah. Wow. Like when I hear you say that, and especially if it's like thinking about trauma, and of course there's so much more that
Yeah.
we like I think sometimes when people talk about trauma or they talk about depression or like we just again just think about what happens maybe in our minds, but not with the chemicals that can be released and how your body's prepared for
Yeah.
all of that. Like the whole system again, which is very interesting. As we then think about treatment, because this is
Yeah.
one of the things that it's hard. Like even in some of the things that I've read or that was published, just in general, when it is pain that is unseen or when it's not described, or if it's described but unseen, we'll say, it's hard to diagnose. It's hard to find this any treatment plans if people don't know what it is. But when people do find out what it is, like what could a treatment plan be for
Yeah. So
vulvodynia?
that is a really good question. And I just want to sort of address the pain that you can't see sort of thing first, if that's okay.
Of course.
So doctors and people are used to acute pain, right? Like you fall off your bike, you have a scraped knee, your knee hurts. And there's a scrape and it's usually proportional to the pain you have, a little scrape, a little pain, a big scrape, a lot of pain. And then as that injury heals, the pain goes away. We're all used to pain, like being in that acute model. And we have good treatments for those kinds of pain, right?
Yeah.
But when it becomes chronic, that injury, the initial injury, is going to sort of disappear and the pain remains. And then a doctor may say, well, I can't find anything physically wrong,
Mm.
right?
Yeah.
Which then implies a psychological thing or something very mysterious that isn't physical. So I think our language really needs to evolve. I think, sort of approaching this in an either or a very dualistic fashion with like a very biomedical approach is not necessarily the way to go. We know that chronic pain exists outside of obvious pathology. Now, having chronic pain immediately sort of like steps up the challenge in healthcare situations, simply because chronic pain is mysterious. It's kind of everywhere. Like a person will have this chronic pain. It's affecting their life. It's, making them feel sad and anxious. It's affecting how they're navigating their day to day. But it's really nowhere to be found, like in the body. It's kind of like taking on this whole life of its own. And it's quite difficult to treat and manage.
Mm.
Yet a lot of people who have chronic pain sort of want very well-defined kind of treatments. And a lot of doctors will try to sort of, meet that. And it becomes a very challenging space to be a patient in. So I think we have to realize that pain can exist without us being able to see it. And it can exist when we don't actually really know what causes it. What are those particular factors? Because who's really looking at people's genetic profiles and how they respond to inflammation? I mean, that's not
Yeah.
really something that, you find in a typical interaction, right?
Yeah.
So, having said that, we do have amazing treatments for vulvodynia, and I will talk also about vaginismus as well. So we know that, and I'm just in the process of finalizing a systematic review
Okay.
that looked at a variety of different treatment approaches and has confirmed what we had put out as recommendations about 10 years ago, that there are very effective treatments for vulvodynia. So first of all, there are psychological treatments that can help reduce pain and reestablish like a connection with a person's sexuality and with sexual desire and pleasure.
Hmm.
So it can't just be a regular, just sort of like therapist that you see. It needs to be someone who is following a therapy that is based in cognitive behavioral therapy, that is targeting pain management, and also has some elements of sex therapy wrapped into it.
Okay.
So this has been shown to be effective for many people with vulvodynia in terms of reducing the pain and, reconnecting to sort of a new sex life. And so that, and I know this doesn't make sense. I tell people, like, the pain is not in your head in this very, very demeaning way, this very paternalistic message that people are getting, right?
Yeah.
The pain is not in your head yet. Using your brain and being able to understand the science around pain, understand that you are not a helpless bystander of pain, taking control of your thoughts, decatastrophizing, making changes in your day to day, having different forms of sex with a partner or partners. These are all within your control, and this is all what we target in that therapy.
Yeah.
And it will expand people's repertoires, and it will give them control over something that they feel is an uncontrollable situation. Um, and so, even though it is not something, a pain, like this pain condition is not all in your head, you're imagining it. If we target your most powerful tool, your brain, we can actually have influence on sort of how much pain you're having, the pleasure that you're engaged, like the pleasure that you're experiencing in sexual situations, etc. There's really good evidence for this. The second one is pelvic health physiotherapy. This is something that I recommend to everybody who comes in to see me who has any form of genitopelvic pain. Not only will a pelvic health physiotherapist help in terms of giving you a lot of pain education, knowing what that link is sort of between your pelvic floor muscles, the feelings that you're having, the fear that you're having, the pain that you're experiencing, and working with your muscles as well as you in painful and sometimes uncomfortable situations in that office,
Yeah.
in order to reduce that pain. And it's very manual, like it's very manual. There's lots of hands-on, there's lots of homework to be done, lots of different strategies that these physiotherapists use. Has been found to be very, very helpful.
Yeah.
And it allows people to reduce that tension in their pelvic floor. It allows them to take control over situations that are painful and feeling that lead people to feel overwhelmed. And it gives people hands-on exercises to do to stretch the muscle, to get used to sort of like the sensation of pain and to release that sort of like tension to reduce that pain. So
Yeah.
this has been proven by research to work very, very well for people with vulvodynia and can absolutely help people with vaginismus.
Vaginismus. Yeah.
And
How
usually
does
what happens,
sorry.
sorry, go ahead and ask.
No, like how does that because of course when we're thinking about the pelvic floor and then we're thinking
Yes.
about the vulva and the pain, like
Yeah.
how like not saying how does it relate, but thinking about if the outside hurts, but the inside is being treated, like of course,
Yeah.
there's likely, as you said, like the brain also
Yeah.
will help with the pain that
Yeah.
is completely like in the vulva.
Yeah.
But I just wondered, like, is it that the pelvic floor, and because of the movement of the pelvic floor, that it contribute to softening or doing something or the pain management in the vulva?
Yeah, and so the pelvic health physio, our pelvic floor there are superficial muscles, so muscles towards the outside of the genital area, and then deeper muscles, right? And so the pelvic floor physios work primarily with those superficial muscles that, sort of contribute to the pain, but
Okay.
also, I have to say, the pelvic health physios I work with are also very good psychologists. They
Okay.
work with that fear of pain. They work with providing education. They reassure, and oftentimes they have a lot of, if you have sensors strapped onto your pelvic floor, you can actually see the muscle activity, and then you can control the muscle activity through different forms of pelvic floor exercises,
Yeah.
right?
Yeah.
And so all of this sort of treats that kind of fear. It actually reduces that tension. And the pain may drop in terms of its intensity. Now, I'm not saying that these treatments will result in pain-free and awesome sex lives, but
No.
they will help more for some than for others, but they will help
Yeah.
in certain. So, we usually say that if you've done about 6 to 8 sessions of pelvic health physio and you're not seeing any improvement, then in all likelihood that won't necessarily work. It's around the same for the psychological approaches as well.
Mm.
And sometimes we actually put them together. And oftentimes when I have a referral for a person who has vaginismus, what I do is I work with them for a few sessions until they are ready for pelvic health physio.
Yeah.
Because sometimes that fear, is so strong that they don't want to go to the pelvic health physio. So sometimes I'll work with them with the goal of going to physio. If they are not at all interested in physio, then we work just us in the session. And we will do relaxation, we'll do lots of education. We do a lot of desensitization exercises. We work a lot with like cognitions and catastrophizing, just to replace like not helpful thoughts with more helpful thoughts. And we have them do lots of practice at home and kind of come back to us. So psychotherapy is also something that can be very useful for people with
Yeah.
vaginismus.
Because with Vulvodynia, I've heard people saying that they might have gotten like a numbing cream or a something, and then
Yeah.
that would maybe temporarily do something, but not in a
Yeah.
longer term. But what I'm
Re-
hearing you, yeah, sorry.
no, remarkably, what we keep finding, unfortunately, is that sort of these medications that are often prescribed. So things like even antidepressants sometimes can help with chronic pain. Antidepressants, anti-epileptic medications, creams, antifungals, all kinds of different medications we have found time and time again and again in this very new systematic review we're working on is that pharmacological approaches do not work for vulvodynia. None
Mm,
of them do,
yeah.
yet they are often considered first line in a medical sort of context. I some maybe they will help some people from time to time, but when you subject these treatments, these pharmacological treatments, to randomized controlled trials, they typically do not work better than placebo, and they may have some undesirable side effects.
Yeah. Yeah.
But I won't say they're not ever going to work for anybody. So
Yeah.
some people may say the numbing cream is beautiful. That works for me. That's what I do. A lot of people with the numbing cream, they're like, well, it's great during penetration, then I'm in pain for 3 days after.
Mm, mm,
Now,
mm.
one treatment I wanted to talk about is only specific to one form of vulvodynia, and that's the provoked localized vestibular pain.
Okay.
Not for generalized pain, not for spontaneous pain. And that is a surgical procedure called a vestibulectomy. And usually surgery does not work for chronic pain, right? And unless it's like a hip replacement because of like hip pain or things like that. But typically, surgery does not work for chronic pain. But there is this surgery, it's a day surgery that's usually done under a general anesthesia, where there's like the vestibule itself in people with this localized pain in the vestibule. It's very sensitive, super sensitive to any kind of contact that comes into that particular area around the vaginal opening. Now, this surgery involves removing sort of like the vestibular tissue to a depth of about 2 millimeters, and then usually sort of advancing the vaginal sort of lining to cover up that exposed area. Different surgeons have different techniques.
Hmm.
And this, after a period of 6 to 8 weeks of recovery, not fun, certainly quite uncomfortable, has been found in research not only to work in terms of pain reduction in the short term, but in the long term as well. So some studies have gone up to 2 to 3 years post-surgery and have found that this is the reductions in pain are maintained over that period of time. And so, right now we are looking at different sort of so these treatments, you need access to healthcare providers, you need access to specialists. So they may not be possible for people to access.
For everyone, yeah.
So
Yeah.
yeah, so at this point in time, I'm trialing this. There's a great sort of like pelvic. There's a online program that was developed by a pelvic health physiotherapist in the U.S. by the name of Evelyn Hecht, and her app is called Pelvic Sense, and we are trialing this right now in a randomized controlled trial
Okay.
to see if this is useful, in terms of pain reduction in people with this very localized vestibular pain. So if people are interested, they can contact me for more information as well.
Okay, I will definitely add that in the show notes. Is there a specific time or date that people have to contact you by, just so I know as well?
We'll be recruiting for probably the next at least 8 months or so.
Okay,
So
that's yes.
yeah,
Then
so
at least this is
I'll send you a
published.
link. Yeah.
Because I'm like, that will speed up my editing process, if
Yes.
so. But it's
Oh
so
yes.
interesting because it's true. Like I've had messages about people who later on finally found out what might be happening for them, and what I said, it might not have been vaginismus, but vaginismus as a result of
Yeah.
something else, and then also as well having had an operation and then actually realizing, oh, that was something that was beneficial for them. As you said, it's not for everyone. It's also depending the localization, but because we don't know, and because we don't necessarily always can pinpoint where the pain is or where it comes and where it goes, or it takes some time to really sit still with you and to be able to put that all together when going into a doctor's office, or for the doctor to refer you to someone too.
Yes. And so it's really important. Like if your healthcare provider is not really. So I do what I do because I want to inform healthcare providers that this is real, there are treatments, and that there are certain conversations that should be avoided with people who have unexplained chronic vulvar pain, because we do know what it's called and we do have treatments for it. And it exists, in the space. And I also want to empower patients to, be able to have really good, honest conversations with their healthcare providers and advocate for themselves. So there's a part in the book in One Sex Hurts that sort of lets people know sort of like how to advocate for yourself and how to sort of, describe the pain that you're having and say, well, you may not have heard of this. I think it's vulvodynia. Can you put me in touch with, or can you consult with somebody, or can you refer me to someone who knows what this is about? Because part of the problem of vulvodynia is long times for diagnosis, long times for treatment, gaslighting along the way, sort of like people being sent home, and it really like it compounds the issues, right? And then we get into what we call the vicious cycle of pain, where there may be like, sort of mental health concerns, right? Where people are anxious and depressed and avoiding relationships. There could be relationship fallout. There could be just so many things that kind of happen while the pain is just sort of there and getting worse over time, right?
Yes, yes. And there's so much to say about even just that, as you said, because I'm not even going to ask you too much about it, but when we're thinking about pain, and as you said, like there is the pain, if it's a chronic pain, how it can linger, how it can be induced, if our brain plays part of that. Like one of the things that I think when I was reading the book, when it was about relationships and how actually the avoidance of, because I was like, oh, if the sympathetic responses of the partners to the pain, and how when a partner would say like, oh, it's okay, that actually could more induce the pain versus that it could help as well.
Yeah.
And it's so interesting because sometimes we take pain as a just a general thing, like this is how you feel it, but how it could be physically, mentally, yeah, how it can keep going on it in itself. But yes, okay. I know that we're running out of time, and I'm trying to think like, what else do I want to ask? And I'm going to start this conversation. But
Yeah.
the most important is that we know what vulvodynia is. We know what could be the risk factors, and we know what possible treatments are. We also will know and likely able to reach out to you and have a list of links that you find that is helpful, which you mentioned in the beginning. But I always like, if I think of ending our conversation, knowing that you
Yes.
have already postponed a meeting for me, because I don't want to feel
I will
guilty.
postpone any meeting for you anytime.
I was like, yes, because we're not done, we can continue. But I'm sure that is not the only time we're going to speak. But
If you would like to see me again, I'm happy to come back.
that is amazing news in my ears, we'll say. But I always love to end the session with or the conversation with just a few facts. Like, and my question to you is like, what is most important myth that you wish to debunk about vulvodynia and vaginismus or
Yes,
vaginismus?
it is. So your symptoms are real. They have treatment, and you are not alone,
Mm,
no matter what your healthcare provider tells you.
yeah, yeah, and I
And
think it's
your
so important.
podcast proves, right? Like I'm hearing voices of like people with lived experience, talking about, their experiences with vaginismus and with pain and their navigation through. I want to say that is amazing and that is empowering for people. And this is something that is on a space where people can access it and feel that they are not alone and feel that there is a name to these symptoms that they're having. I also want to say that, penetration, like penetrative sex, certainly can be really important for certain people. But also, you are also allowed to, and not as part of as avoidance, but as part of a choice to choose not to engage in penetrative sexual activity either, right?
Yeah.
And that depends, sort of on who you are, who your partners are, and sort of what your preferences are. So maybe our sexual script in our, sort of cultures are saying this is what sex is. Maybe you want to define sex as something different that gives you pleasure that may not involve penetration as well.
Exactly, exactly. Like we have a choice as well.
Yeah, yeah,
And what I love of our conversation today is that there's so much, like, I think, information out there, and even if it's just through this conversation, I think people would you've given people already so many different definitions and different things to look at, to think about. If it is from, like I have been taking other medication that might have caused me flare-ups, like when you spoke about inflammation, like now going to perimenopause. Oh, like I'm about to start my period. Just sorry, a lot of information just for everyone now, but I get so inflamed in my neck
yeah,
around that time, and I have gone through I had gone through all kinds of things that I didn't know. I didn't put it one and one together, and now it's like, actually this is hormonal. They've put me in an MRI already. They've put me in all kinds of things of random inflammation that I had over the last year or so. So I can only imagine that like your vulva is not something different from that. It's also,
exactly.
yeah, like
Yeah,
a flare up could be anywhere.
absolutely.
It's just a very, very annoying, uncomfortable spot.
Yeah,
And yeah, especially a spot because we don't necessarily want to run to the GP
yeah.
and talk about it at times. But I do love the fact that you've given us so much today. And if I could end with you, and if you have like, our vulva is, have you have an empowering sentence? Our vulva is.
I would say powerful, and it really like It is super powerful in so many ways. It can bring us pleasure. It can bring us a lot of self-reflection. It can bring us a lot of grief. It is the subject of, sort of indirectly and directly many conversations about women's reproductive rights and health, sort of these days, especially in certain countries and certain areas. So I see it as a symbol of power. And I also see it as, something that you also have control over in terms of its power over you. So I see it as this like, this iterative process in terms of, sort of talking with a lot of people who have vulvodynia and issues, where they come in and they are, are really identifying with their issues. And I like slowly through the work that we do, I want them to empower themselves, to imbue their, vulvas and vaginas with more positive power and to have that negative hold in their life become less,
Yes.
instead of central, right? And so a lot of the work I do is there as well. In terms of just kind of broadening and expanding people's views,
Yeah.
and their seeming, sort of like helplessness,
Yeah. Yeah.
and to change the narrative with their own vulvas. Yes.
Yes, exactly. Like I always think like knowledge is power in that sense too, so and so if someone wants to reach out to you, like of course I will add it all in the show notes, but what best way can they reach you?
Yes, the best way is through email, and I'll give you my email. I'll give you like the shorter version of it. So, it would be my family name, which is pronounced Pukall. So P as in Peter, Ukall, and then C for Caroline at queensu.ca. So QUEENSU.ca.
Amazing, amazing, amazing. It's like I hope that people do and don't hesitate to reach out to you. I will add that as well if they need to copy and paste, or see what the next research is that they could maybe participate in. Not only that, you mentioned other links already before. We will write them down and we'll get that there. But I will
Yeah.
definitely think about more conversations to have with you because I feel we had to be like, okay, this is how far we can go, but I feel we there's so much more to discuss. But I'm just very grateful for you to be my first, and who knows, it might be my last this year. Who knows? I don't know. I am just going with everything these days, but I'm so happy that it's been with you.
Thank
And
you.
also, let me just actually, I know we've got only a few more minutes, but you also, and did I, because all of a sudden, hold on, I have to get it right. Hold on, hold on. There's also a book that came out this year. Was the Human Sexuality
Yeah.
a contemporary introduction?
Yes,
What is
that
that
is
about?
that is a human sexuality textbook, that people could buy just for fun, but also it like is rolled into a ton of human sexuality courses like across Canada, and so yes, that literally the box just landed on my desk on Monday, so just this past
Wow.
Monday. That is the brand new edition. It is now in its fourth edition.
Okay,
So the
okay, okay.
first one was published in 2017, no,
Ah,
2014, 2017, 2020, and now 2026. So
okay,
that is
okay,
a
okay.
whole other sort of, and so it's not just focused on vulvodynia, it's focused on sort of cultural influences. It goes through basic anatomy. It talks about research in terms of pornography, sex work, sexual dysfunctions, sex toys, pleasure, all sorts of really, really, really cool things, as well as how do people do research? What are some of the common methodologies out there?
Yeah,
How do people study this,
yeah,
right?
yeah,
And
yeah.
it does touch upon sexual health education as well.
Okay. Wow. Okay. So that's because as you said, it's come back. I will
Yeah.
look it up. I will also put it out there. The book as well, what I originally contacted you for, which as well, knowing that there are multiple co-authors and other like great researchers in there is the book When Sex Hurts. But I just wanted to thank you for your knowledge and your research in the field, and also for giving me and others that I know who have been trying to do their own research or like have a mini study and being like, okay, I now know. But I'm far from a researcher. I love this space and the coaching space. But I just want to thank you for your inspiration, because I think it's so needed, and for your work in general.
Well,
And
and
thank you for your time today.
goodness. Well, thank you very much for your amazing podcast and for the fact that you are coaching people who need coaching, and for just sharing your own experiences on your podcast, and for everything that you do like this, and for having me on your show, and for being the first 2026 interview for you.
Exactly.
So thank you
you
very, very much.
No, thank you. But I will also thank our listeners. Like, thank you for coming back, for listening. Please reach out to Caroline, reach out to me. We're here, and regardless. But yeah, I look forward to hear what everyone thinks, and and maybe Caroline will share with me as well, if there's people coming to her. But thank you for listening. This was the VME podcast, Vaginismus, Let's Name It Not Shame It, with Audrey Cairo. Don't hesitate to reach out or to connect on Instagram on Let's Call Her V, or find any other details about coaching and workshops on audreycairo.com/VNMe. The aim of the VME podcast is to support, inform, and to empower you. And if you're walking away with just a little bit of that and you wish to support, please visit buymeacoffee.com/v.nme podcast, or simply check the link in the show notes. Please know that while podcasts can be a great source for information or stories, this is not a source or substitute for professional medical advice, diagnosis, or treatment. So always consult a qualified medical professional for any medical support. And while it might be scary or difficult sometimes, don't forget to ask for what you need. You got this. Thanks for listening.